be simple, and you think you already know about this, but the practice and implementation of this consultation process require a lot of practice, personal practice, experience, as well as increasing your knowledge by educating yourself of several conditions that you might not have seen before. Now, so consultation liaison psychiatry is a subspecialty which is defined as the specialty within the psychiatry, and it's at the interface of medicine and psychiatry. So it includes three important principles, which are clinical practice or clinical service or service delivery, teaching. Both our colleagues, psychiatric colleagues, as well as colleagues from other medical specialties, as well as the paramedical staff, plus the medical students and junior residents, and so on and so forth. So it is a very important subspecialty, and it's actually, sometimes we call it this specialty is at the forefront of the medical specialty among all the other psychiatric specialties, because here we interact with physicians and surgeons, and we play a very important role in the care of these patients. There are some other names given to this subspecialty. You might have heard of these names: psychosomatic medicine, which is actually losing its interest now, because we are not using this term often. We also, in some places, it's also called general hospital psychiatry, particularly in the US. And then in the US also they have a name called medical psychiatry, and that is something to do with the medical insurance, because in this particular format, the psychiatrists actually take care of some of the medical conditions as well, which is not the case in many other parts of the world, and that's, like I said, mainly for insurance reasons. Okay, there are several models of consultation liaison service, and the most common one is a consultation upon request. So this is when you get a referral from a doctor from the ER or from the floors, and you go and see the patient, and then you manage the patient. The other models are called a liaison model, where the psychiatrists work very closely with certain units in the hospital, so the psychiatrists become part of that team. It's called the liaison model. Some examples are neurology. Psychiatrists can be part of a neurology team or a renal team or rheumatology team, etc. Because of the funding issues, we are not really particularly providing this kind of service, because the medical units are not able to fund us, and the psychiatry also is not very keen to send a psychiatrist for the entire time with a medical unit from their own, and the money is going from the psychiatrist's pocket. So the psychiatry senior managers are not very impressed. So therefore, this particular model is not getting very popular these days. Now, we also see patients in the ER, particularly in the HMC, consultation liaison psychiatry actually manages the ER. So we got a role to play. Although for training and accreditation issues, a pure ER psychiatry is not part of CL psychiatry. That's historically the case. But now with the new expansion of these models and understanding, then we are also incorporating ER in the CL umbrella, under the CL umbrella. Then we have the other models. You heard about the collaborative care model. Collaborative care model is where you provide psychiatric care to patients in the primary care, the primary health care. So where in many parts, especially in the UK, this is a very popular sort of model. And inshallah, in Qatar too, we, as you all hear, that there is an emphasis of primary care, psychiatry, and there several psychiatrists are placed in the community settings and also in the primary care settings. So therefore, that model also would come under CL. Then we have in the US and several other countries like in Australia, we have very large programs purely dedicated for that particular medical units. It's called the psychocardiology program, psycho-oncology program. So very big cancer centers you have heard of. And they also have a big psychiatry team working within that medical umbrella. So that's a very big unit. And the advantage of such model is that you can come up with really fantastic research ideas and also the opportunities for coming up the new way of understanding the psychiatric disorders are really, I think, important. Again, it requires a lot of funding and commitment from the senior management. But interestingly, in all these models, like I said in the beginning, the three pillars are very important. The clinical service delivery, the education, and the training are extremely important. Now, what kind of patients usually you will come across in the CL setting? I'm just checking, can you all hear me properly?
I can hear you.
Yeah. Excellent. So there are several categories of patients we see in CL setting. I won't go into all the details, but I'm just going to give you a bit of list of conditions. We see several cases that are complex, where you have a comorbid psychiatric and medical condition. Okay. We also see patients with neurocognitive disorders, for example, dementia of various types, when they have associated medical conditions. We do see a number of cases, we call it somatization disorder or somatoform disorders, and also specifically in the neurology setting, we see patients with functional neurological disorders, also known as conversion disorders. Then we see a number of psychiatric presentations of medical conditions. We usually see that in the ER setting, because sometimes patients present with a medical, like for example, a panic attack or severe loss of weight or apathy, and so the psychiatrist might be called in to assess for depression. But it would turn out that these patients would have an underlying medical conditions. Another, I can give you a good example is that someone who is very confused, but clearly psychotic, with some catatonic features, and eventually first onset. Eventually this will turn out to be a psychosis due to an immune pathology. And some of you have heard of the condition called the NMDAR encephalitis, the autoimmune encephalopathy. Okay. Now, another function of a CL psychiatrist is the assessment of mental capacity. So what that means is we are asked to assess patients. Just hold on a second. Okay. So we are asked to see the mental capacity. What that means in practice, we expect all patients admitted in the medical ward or psychiatric ward to make their own informed decision about the treatment. But sometimes this decision-making capacity can be impaired due to some other problems. For example, patients may have severe cognitive impairment, or patients may be very frail and very severely depressed, and they are not able to make the right decisions. So sometimes the physician asks the psychiatrist to assist them to see whether this particular patient has got the capacity to make any decision about their treatment. Then, not uncommon, we do see sometimes systemic issues within the consultation liaison practice, because the referral would be something like we have a very difficult patient, or we have a very difficult family, or maybe you can say that a patient is not happy with a particular medical team. So when we go and see these cases, we realize that there is nothing wrong actually with the patient. It's actually the problem with the system, because the patient may not have any privacy. Some nurse was rude to the patient. The patient did not have the meal at the right time. So we call it the systemic issues. So please don't dismiss this as not important, because these are also very important issues, because we got a role to play as a mediator in these kind of settings. I will give you enough time at the end of this presentation to ask questions, but to avoid any disruption in the flow of my presentation, I think it's better I will finish with the presentation. I don't have a lot of slides, but and then we'll have plenty of time to interact and discuss, which I think is the most important part of this whole exercise. Okay, so why is this consultation liaison practice, which is actually seeing a patient in the ER or in the medical floors, different from office-based consultation? Office-based consultation, I mean, is seeing patients in the OPD clinic. So why is it different from you see someone in the hospital? They are different. First of all, most often, almost always, the referral in the hospital setting is coming from a consultant, either a physician or a senior nurse, or maybe a fellow, who would be actually sending the referral to you. So always there will be a consulting, and most often there is no self-referral. Then that means that we have an obligation both to the consultee, the person who actually referred the patient, and also to the patient. Now, another things you need to consider that is different is that sometimes patients in the hospital are unaware of the referral. So we often turn up without the patient knowing that a referral has been made. Okay? Or you go and turn up there, the patient was already told that a psychiatrist is coming, but unfortunately the patient is very sick, very frail, very uncomfortable to see someone on a particular time, and also the patient may be experiencing severe pain. So it's very different sort of settings that you assess these patients. Sometimes you go there and turn up, you have this introduction and conversation, and the patient appeared to be not motivated to talk to you at that particular time. I'm sure that some of you have experienced that. You turn up, you're very hardworking people, you turn up, you find a time, and the patient says, "Doctor, I'm really, really tired. I don't want to talk to you. Can you please come and talk to me sometimes later?" So this is not uncommon. You need to understand that we have to cope with this situation and to adapt to this situation. Sometimes there may be some cognitive impairment which has been undetected by someone else, and that would be a determinant of the reason for poor motivation. Sometimes it is the lack of privacy. So you go to the ER and you would see several patients, in the cubicles, and often separated by a thin layer of a piece of cloth, a curtain, you call it. And so you can have a conversation, the other person in the room and the family would be just listening what you're talking about. And the patient you are interviewing is not going to tell you, because it is personal information, because there is no privacy there. So you need to understand that how do you adjust to that situation. And then another most important thing is, I always keep reminding my colleagues that the consultations are not scheduled. So on a particular day, on a particular time, you have nothing to do. You only have time to have coffee and sitting and having a chat. But before you are going home, just about to pack your bag, suddenly you have 4 consultations. So this is part and parcel of our job. So the consultations are, we call it not scheduled and not time based. So you can come anytime. So you're supposed to see that patient whenever that referral comes on board. And I'll talk to you, we don't have much time to talk more about this particular thing, because there are many ways we can categorize what is an urgent consultation, what is not so urgent consultation. So we'll probably have some time to discuss at the end of this. All right. Now, an essential part of psychiatric consultation is the doctor-to-doctor communication to address the mental health needs of the patient and the improved patient care. This is very important because communication with your colleague for the better management of that patient is crucial. So communication is a key important element in the consultation process, and I have found it often missing because of several reasons. The doctors may be very busy, or they don't really care about talking to the colleague, or they've got too many referrals to do. So therefore that communication is broken, and you might often write something on the Cerner and you just go on to see the next patient. And unfortunately, it's not a very effective way of consultation. And at the end of the day, the overriding concern is not about anything else but the patient's overall well-being. Now, so what are the essential tasks for a CL psychiatry physician? In order to be effective, you should provide a complete and comprehensive psychiatric assessment, and you should develop a clear management plan. And then you should also be able to remove some impediments of medical care. There are many barriers and difficulties that patients experience in the CL setting, in the general hospital setting, and you have a role to remove some of those impediments. And then very important is that sometimes, like I said in the beginning, the title of this talk is The Art of Consultation, because sometimes you go and see a patient and the referring doctor knows that the patient is depressed, and it's not a very difficult thing to make sometimes, and you also go and say this patient is depressed. So it may not be, there is no fresh perspective in that. So it might be very important sometimes to bring a fresh perspective by reformulating the whole context. So you can say much more about the depression. Why is this patient depressed? So you can also explore some dynamics of these patients. Also, you can explore some other aspects of biological, psychological, or social aspects, and you bring a new perspective to the clinical dilemma, if there is a dilemma. But even if there is no dilemma, you can bring up some fresh perspective, and that's really, really important. Now, another function is to facilitate a mutual understanding between patient, doctor, and the treatment team. See, sometimes the communication barrier among all these parties are disconnected. So you have a role to play by connecting the patient with the treating doctor, the other treatment team. So sometimes we call the MDT, and if there are some issues which you find it very important that the patient is not getting the best care, you can actually facilitate a team meeting to improve that understanding, the understanding of the various issues that all the team members and the patient should know. Okay, so that's a very, very important role that you can play. Now, also you have an important role to educate about the emotional and psychological needs of the patient, if that's relevant to the referral. Now, let's just now focus on the various steps in the consultation process. So there are several steps which I will walk you through slowly. The first steps in the consultation is that before you see the patient, you should review the previous notes. In our case, the electronic notes, the Cerner, that's what we have. So you should quickly skim through all the previous notes, at least in the last few days or few weeks since the admission of this patient. If the patient had any previous psychiatric consultation or similar problems, it will also give you an opportunity to to get some information on that. And then you can also check what actually is the referral question. Why is this patient referred to you? So that's also very important. And ideally, in all possible cases, if you are not satisfied with the electronic data, you should be able to talk to the consulting, the referring doctor. This will certainly help to clarify what exactly they are asking for before the consultation. So you can focus on the consultation. Now, very important, you should discuss the case if possible. Certainly in my view, I think in all cases, you should, after the consultation, after the assessment, you should speak to the referring doctor. And then you can then clarify that where you have missed anything, misunderstood anything, or did the consultation process was complete and the referring doctor was happy with the management plan. Steps 2 in the consultation process. I think it is very, very important that you introduce yourself before you start talking to the patient. And the patient should know who you are. For example, are you a resident? Are you a fellow? Are you a consultant or a senior consultant? And I think it is extremely important for the patient to know who you are. Now, I strongly always recommend that you should sit down if besides the patient, if a chair is available, so that the patient knows that you are not in a hurry. You're not really standing over the patient, and the patient is lying on the bed, and then you're standing over and shooting questions without even telling the patient who you are. And that's a very, very unprofessional way of doing it. So therefore, make sure that you sit down comfortably with the patient if possible. Now, if the patient was not informed about the referral of a psychiatrist coming and assessing, and you can address if they have any concerns in terms of this referral. A very well-informed patient, I had several occasions when I was consulting very well-informed patients, they were referred without their knowledge. And some of them, they knew that a psychiatrist was coming, but they didn't want to make their referring doctor upset. So when I arrived, and the patient very respectfully told me, "Doctor, I know I am upset, I have some issues, but I'm not really happy to talk to a psychiatrist." And then it is absolutely fine to thank the patient and offer another opportunity if the patient wishes to come and patient wishes to talk to you later. And that's and you should not, because the patient was referred to you, you have no obligations to forcefully, impose a psychiatric assessment on a patient, and that's very unprofessional. And I think also that is not appropriate. Okay. Now, I would always make sure that, especially when I'm seeing a very sick patients, if they are in any form of physical discomfort, or if they are lying down, patients with breathing difficulties are lying down in a very awkward posture, and you're going to make a psychiatric interview, I don't think it is very appropriate, and you won't get any good information. So make sure that the patient is propped up comfortably. And if they are not getting enough oxygen, you make sure that they get oxygen. You can even offer a glass of water if it's available there, to make sure that the patient is okay and comfortable to talk to you. Patients with severe pain, make sure that that also is attended before the psychiatric interview. Consultation steps 3. Very important, do a proper mental status examination. We should observe the patient's you should do a very good mental status. That means while talking to the patient, you should also observe this patient's various behavior and other aspects of mental state. And you should also be very good in doing a bedside cognitive examination. Certainly in most patients, you can do mini mental status examination, but you can also add on some additional tests like a clock drawing, or some frontal lobe testing, etc., depending on the situation. If it is appropriate, if you think that the physician has missed a particular aspect of the physical examination, you can do a targeted physical examination. So I'm not suggesting that you are doing a complete physical examination for a patient who has already been under the care of a physician. That is not a very effective way of utilizing your time. However, if the patient missed some fine tremors of a hand or some funny movements of the head or some kind of abnormalities, neurological abnormalities, and if you haven't actually seen that in the physical examination by the physician, you can do a targeted physical. That's what I mean. You do a targeted physical examination, and of course, it's very important to collect collateral information from the family caregivers and maybe in other settings, some doctors, previous doctors in the family doctors or other physicians who treated the patient before. Steps in consultation 4, you should have a written note because in the good old days we used to write very brief, nice, precise consultation, but now we actually write on the Cerner. And I already alluded the importance of verbal communication with the referring doctor, and also you should think about this after your first assessment whether this patient needs to be seen again. And I think it's very important. Sometimes the consultation will be one-off. A capacity assessment usually is just one-off, and you don't really go and see this patient again, Or a patient who's going to be discharged home, and then the physician is ready to discharge the patient home, and then they are asking you to do a risk assessment. You go and see the risk assessment. That follow-up is not really needed in the hospital setting. That's what I mean. But someone who is delirious, has been in the ward for a few days, and you started the patient on some small dose of antipsychotic, you can't just leave the patient with that dose of antipsychotics and come off. You should, in that case, make sure that when do you want to see the patient and how often you want to see this patient. Also important, you should tell your colleagues, because you may be on leave or you may be on shift duty or whatever, and you're not available the next day or the day after, you should tell your colleague that how often that patient should be seen. It's very important. Now, written notes, another important information I want to convey is that you should ideally address, write the document addressing formally to the physician who requested the consultation. But of course, it may not be possible all the time to find who, the doctor, if that's not clear. I think you should at least make a referral, if possible at all, identify the physician who actually referred you and address to that doctor. But if you're not sure, you just write generally, that's no problem. And also I want you to be very, very careful with this important bit of information, that you should be extremely mindful that the notes are accessible to various variety of staff. So you should be very careful in writing your notes, especially writing sensitive notes about a particular case, because the patient in the medical unit is admitted for a medical problem, and then for some reason you are interviewing and the patient tells you lots of personal information, and you put that blank on, put on straight away into the Cerner, and the physician colleagues or some nurses or some other people would read it and say, whoa, and then we never thought about this patient had all these kind of issues. So you had to be extremely careful what to write and how to write. So for example, I'll give you, if the patient gives you a history of childhood sexual abuse and no one knows about that, the patient revealed that in the consultation, it's just not appropriate to write in the medical note that this patient was abused sexually by so and so, even the name or the relative or whatever. You can very convince that this patient had a very traumatic childhood experience. However, due to the privacy and confidentiality of the nature of this trauma, we are unable to document the details, something like that. So that means you are not avoiding any, you're not missing any information. And if someone wants later, they, in a very private setting, they can explore that rather than you write explicitly in the notes about this. Okay, very important. When you are a resident, you are in the CL, you're posted with us. You go and see the patient, and you might be the one who is writing the notes. But please write on the Cerner CL psychiatry. Even if it doesn't really show up on the site, but in the notes, in the final report, so when it comes, you should read that in bold letters, CL psychiatry. It's very important to identify. Otherwise, it will be missed. It would be some other specialty, and people won't be interested. But if you write CL psychiatry, it's very easy to identify. And you should also identify yourself. Consultation by a fellow. Are you a fellow or a consultant, like I already said, etc. Then you should say first assessment. You can call it initial consultation. So CL psychiatry, Dr. Mohammed, resident, initial consultation. And then in the follow-up, you should also be able to say the follow-up consultation, when would you be able to see this patient again. Then I would still encourage that you can still put the date and time. Sometimes it's putting the date and time is very important, because the time is very important, because sometimes you can be challenged by one of the physicians that, you were called and then your colleague did not turn up, and then after 8 hours of 10 different calls, you came to see this patient. Okay, so you can say that, look, the call came in for assessment of someone with depression. We received the call at 10 o'clock. We had 10 different referrals. We saw this patient at 12 o'clock or maybe 2 o'clock. You see, it's all recorded on the note. Rather than you don't put the time, you can't defend yourself. It may be just a 2 hours delay, but it's acceptable. 24 hours, a routine referral is acceptable. Unless, so your life could be a lot easier if you put the date and the time particularly. And of course, you can write the collateral information and also some other information. Now, I would usually start the writing up with some kind of an introductory statement. So I'll come back to that a bit later. How do you do that? I think it is in the next one. Okay, so before I go into the written notes, I just want to give you a little bit of additional information here. Now, it's very important that you need to know exactly what is the reason for this consultation, because there might be a hidden agenda within that referral process. I have often come across this because there is something called the manifest request, which is exactly what the referring doctor is asking for. Doctor, please come and see this patient who is a 45-year-old woman with recent stroke and is currently depressed. Can you, very straightforward actually. Sometimes the request is manifest. Please come and assist this patient with depression. But there may be a latent request. There may be a hidden agenda. So maybe a drug abusing, manipulative, difficult patient. No major psychiatric issue there, but they want just you to come and see. You would simply refuse sometimes because you're busy. I'm not going to see this patient. This patient is just some PD and a drug and alcohol problem. We can't offer much. So therefore, the referring doctor is very clever, and they have a latent request, what we call it. They say that, can you come on this patient? He appears to be agitated, anxious, and depressed. When you go there, yeah, patient is agitated, but the request is that he is a drug abuser, is withdrawing, and is making the medical team's life miserable. So just be mindful of that. Okay. Now, so this is what I was alluding to, a written note. So you can start with something like this. So this patient is 34-year-old female, admitted for abdominal pain with a history of multiple medical complaints. If you want to be more specific, you can write that within the bracket or maybe below. And pain unresponsive to usual medications. We are asked to evaluate her for possible depression. See, when you write something like that, it is very clear that what was the reason for consultation, and you're rephrasing that. You're actually reiterating, that referring thing, so there is no misunderstanding. Because the patient would say, the referring doctor later would say, we thought this patient was agitated, but, then you would say, well, please see the request, please read the written note. The request was for assessment of depression. So we specifically focused on the assessment of depression. So in that way, if you see additional problem there, you can always formulate that and help to manage the patient. But this is much more effective in terms of answering directly to the question asked for. Okay, so in the written notes, there is no need for a very detailed account of all the problems, but you should be able to give summaries of history of the present illness, document the essential positive and negative aspects, use precise phenomenological terms to arrive at your diagnosis, rather than writing woolly, some vague sentences, but you come up with some very precise phenomenology that we all use in psychiatry, like delusions, hallucinations, disorganized thinking, etc., or compulsions, obsessions. That's what I mean, rather than using very vague sort of lay language. And also you should consider in assessing this patient's major life events, like particularly in CL setting, losses, illnesses, current precipitancy, if any, and the nature of patient's reaction to these events, because this patient is facing a very life-threatening illness, recent diagnosis with cancer, for example, very advanced stage, and you need to understand this patient's reaction to that illness. Sometimes, although we don't teach a lot of dynamics here, I think psychodynamics is very, very important in the psychiatric setting, in the CL setting, to understand this patient's various defenses and the emotional reactions in order for you to be very, very effective and to have this art of consultation. It's not about collecting some data and prescribe an antidepressant. That may be the science, but the art is to understand who that patient is and using the various psychodynamic theories and the principles to help that patient to manage their medical conditions better. So I won't go into all the details. I will just simply list so that we have more time for discussion. So just to let you know, for completion's sake, you should have the past medical and surgical history, past psychiatric history, medication. Current medication is very important. So what happened to the patient prior to the admission? Have they been given some medications? The reason is that sometimes the psychiatric presentations would be due to a medication prescribed. So it's very important that the patient, like for example, patients given steroids, for example, or recent escalation of the dose of a particular drug, even steroids or some other drugs, and then the patient develops psychosis. So it's very important to get the medical history and the medication history. Substance use history, many times the doctor thought that the patient had some kind of psychosis, and we assessed the patient. It turned out that the patient had Korsakoff psychosis, or alcohol-induced some delusions or psychosis, maybe related to something completely different. Family history is very important, so also the other social history, etc. Now, physical examination, if it is appropriate, you can document, like I said already earlier, but if it is not something which you think is not relevant, you don't have to waste your time in rewriting the whole thing. Mental status examination, I think is very important to have history summary, and mental status examination, it should stand out as a separate sort of subheading with the big M and SE, so that the physician would know that you observe certain important phenomena, and that's, I think it is very, very important. That's our main tool in making the right diagnosis. And of course, if you think there are some relevant laboratory and radiological findings, you can use those information in your formulation, because if someone who has got, let's say, delirium or some kind of confusional states with some psychotic symptoms, and if you think the patient has got an MRI brain scan that shows hypoxic encephalopathy, significant white matter changes, or an EEG showing some spikes in the temporal lobe, things like that, or some abdominal blood test, you can say that would help us to confirm our diagnosis that this is an organic brain disorder rather than psychiatric disorder. So it's very important to document that if that's relevant. Sometimes I think you simply write something like delirium, and you don't remember I told you that they made a diagnosis of delirium. You also make a diagnosis of delirium. No big deal. So sometimes in this case, with some additional neurological findings, MRI findings, and often you can bring a new perspective. You can be much more precise about the nature of this delirium. Could be encephalopathy. It could be toxic encephalopathy. It could be post-ictal confusional state. Because there is an EEG evidence. You understand what I'm trying to say? So that's what I mean, bring fresh perspective. Sometimes you will be really surprised. In my practice, I've seen come up with these kind of fresh perspectives, help me to publish some fantastic case reports, which no one would have thought about, and the physician would have never thought about that. And they would be happily raising their hands that we want to join the publication. So keep your academic rigor and the curiosity within you when you are consulting, not just being there, just another case. So bring some perspective all the time when you see these patients. Okay, and then very important, you should write your impression, psychiatric diagnosis. You can either say impression or psychiatric diagnosis. And it has to be very clear and succinct. If it is depression, you shouldn't say just write depression. You should say, is it major depressive disorder? Is it dysthymic disorder? Is it an adjustment reaction with depressed mood? Or is it depression, major depressive disorder due to underlying medical condition? So be very specific and succinct. Don't write too much in the impression side. The diagnosis has to be very precise and succinct. And always, your tool, your advantage as a psychiatric resident is that you can use the biopsychosocial formulation better than anyone else. I think you are in a much better situation to do that formulation. And very important, you should avoid various kinds of jargons. Some of the jargons that you should avoid, especially psychodynamic jargons, like repression, sublimation, first of all, you wouldn't know what you're talking about, and second, the physician is least interested in finding out your psychodynamic jargon. So try to be simple, but not just they're using the lay language, but precise, simple formulation, but not jargonish. And write out any stressors the patient currently has. So because when you identify stressors, the treatment, the intervention is not medication. You need psychologist, psychotherapy, so it's very important. And also you should assess the functional ability of the patient. For example, if the patient is very disabled and the depression is from the disability and the patient is not getting enough physiotherapy, you should recommend that this patient's depression is coming because he's not getting adequate physio. So in your recommendation, you can say that this patient requires more physio in your way, in your opinion. Okay, and I would strongly recommend, if you're not clear about the diagnosis, I think often it's the situation. But for a senior consultant, it would be very absolutely clear. But don't go down that path. As a junior, as a resident, as a fellow, you should always consider differential diagnosis. No matter that absolutely there are no differential diagnosis, but you still should think what else it could be. So that should always be there. But of course, you can say that the most likely diagnosis here is this, and you have to treat that condition. But that doesn't really mean that you cannot consider differential diagnosis. Very good way of exercising your clinical acumen by thinking these differential diagnoses. Now, I have no particular, liking for a particular classification like ICD-11 or a DSM-5, but my training mostly has been, in the initial part of my training, I was trained with ICD-9, but later when I relocated to Australia, so mostly they were following DSM classification. So I'm more familiar now with the DSM-5, DSM-4, DSM-5 rather than ICD-10-11. But I have no issues if you like ICD-11, why not? No problem there. But what I'm saying is that don't doggishly following the criteria, as such, but what I'm saying is that you should have some framework in your mind. You don't have to say, with this patient has a DSM-5 major depressive disorder. I don't think you should say that. That's very, very silly. But you should say that the patient has a major depressive disorder, but you made that based on that framework that with DSM-5. But you also used your other skills of formulating that case, the dynamics, the social issues, the psychological issues. That's usually not reflected in DSM-5. That only comes in your psychiatric assessment. So that's why we call it diagnosis is just one aspect, and psychiatric formulation is the most important aspect of that diagnosis. Both are important in my view, and both provide different functions. Okay, so that's important to remember. And then the last part, the recommendation and plan. And sometimes you will be surprised. The physician colleagues probably are not interested in anything that you wrote. They won't be even reading your assessments. They won't be even reading your diagnosis. They would immediately go to one thing. What is your recommendation? What's your plan? What's your plan, doctor? What's your plan? You always it's very annoying, right? When someone is asking, we finish the consultation, you come out, you say, doctor, what's your plan? So it's really, I think, very important, because that's what they want. They really want a clear plan. So you make sure that before they come and ask you what's the plan, you write out a clear plan. So when you write out a clear plan, you know what the plan is. When someone asks you what's your plan, yes, my plan is 1, 2, 3, 4. Don't be annoyed, but you just plan, because you already you thought about the plan. Now, if you think the recommendation includes further workup is suggested, you say that. I haven't finished my assessment, but I think I need more assessment, and I also need a neuropsychological assessment, for example. So you can say that additional work involved. You can recommend medication. Make sure that you write the medication's real name, a generic name, and the dose and what time it should be administered. Don't just write that. You can, please try risperidone, and you just come out. Please don't do that. You say, tab risperidone, 0.25 milligram, to be given 7 o'clock or 7 p.m. or 8 p.m. At night. So be very specific about that. Excuse me. Then, if you think there are some other issues that need to be attended to, you should address that. For example, legal issues, social work needs, patients who are like nowhere to go. So patients, because in Qatar we have a big expatriate population, so sometimes we need to understand what's their legal status, residency status, etc., etc. So that you need to be just thinking about, not just seeing that patient and forget about all the social aspects, but you should be able to understand their social situation, and you can help them. Right. Okay. Like I already mentioned this in the beginning, that what is you can be very effective in the CL process if you have very complex cases. In my last 25 years of practice in Australia and in other places, I came across several complex cases, and I didn't know what to do, because and I found that first of all the neuropsychiatric diagnosis was very challenging. We could only have speculations or differential diagnosis, but much more challenging was that the communication was broken. So and then everyone was saying that people are disowning the patient. For example, the physician would say, we have done everything we can, but it's psychiatry. But we are saying that, yeah, you have done everything you can, but this is not a clear psychiatric case. And there will be 3 or 4 physicians involved. But mind you, I'm telling you that some cases there will be 4 physicians included: respiratory, cardiology, renal, and people would conveniently, if it is a complex case and if that problem is not prominent, will wash their hands. That's the experience. But in order, at the end of the day, we want everyone to work together. Then only you get the best outcome for that patient. So therefore, as a psychiatrist or a resident, it's your call. If you think something is happening, it's a complex case, you can be a facilitator for an MDT, bringing all the stakeholders into one table, and then you discuss. Okay, and there's not much so about the medico-legal guardianship, mental health act, etc. in our context, but in the future, in the near future, I am envisaging that many of these aspects we will be dealing with, like the medico-legal aspects, the guardianship issues, and the mental health, etc. But at the moment, I think we are pretty, I think, okay. We don't have to get too much caught up into this, but we can expect that all these come to us on our way soon. All right, so here are some of the references. I have a number of references I have given here. I will also, this is my last slide, I will also make sure that I'll send you all the slides for your review and for your learning. But now I would stop here, and then you can ask me some questions, or you can make comments. Okay, thank you very much for your attention.